So my task today is to talk about cardiovascular residual risk with a special focus on the role of atherogenic small dense LDL. This is my disclosure. I have done a lot in the last years with pharmaceutical companies, but it's pretty much balanced. And then this is the agenda. You are assigned to me 45 minutes. That is very nice, but it's a long time. So I hope not to bother you too much. And I will start with some historical data. This is linked to the Framingham study. So we are talking about something like 35 years ago. And it was clear since the very beginning that cholesterol is not fully adequate to predict cardiovascular risk. So it's a good marker, but unfortunately cannot discriminate cardiovascular disease from healthy subjects. So basically, in other words, we can have the same cholesterol levels, total cholesterol levels, or LDL cholesterol levels in a subject with a cardiovascular disease or in a healthy status. So there is no discrimination. And even more, this is the lesson that we learned from the large cardiovascular intervention trials, the use of statins, the AIDS. So it was clear since the beginning that there is a lot of residual risk. And this is also what we see every day in our clinical practice. So with patients with statins, with lipid-lowering drugs, with antihypertensive drugs, with antiplatelet drugs like statins. We now have even fantastic modern anti-diabetic drugs, but still patients do have cardiovascular diseases. They still unfortunately have acute myocardial infarction, they still have stroke. And we know that in Western countries, like Romania, like Italy, cardiovascular disease is still, unfortunately, the first reason, the first cause of mortality and morbidity. So it's a huge problem, and there is a lot of residual risk. So we need better tools. We need better markers, cardiovascular risk. This is why, about 10 years ago, we reasoned to create a European panel of experts, and the chairman was Professor Michaelidis. I think that today, this morning, you had the pleasure to a lecture from Professor Michaelidis and Dr. Ziki. So we created this expert panel of European colleagues in order to make a statement on the pathophysiology, heterogeneity, and clinical significance of LDL subclasses. So going deeper, not talking about LDL in total as a quantity, but going deeper with the quality of LDL. I really hope that you can still hear me well, and
we are hearing you.
Thank
Manfredi.
you so much,
Okay.
Chris. So, briefly about the heterogeneity of LDL. Lipoprotein metabolism is not so nice to study, since it's a little bit confusing, different major classes, so many subclasses, and each subclass has distinct properties in terms of metabolic behavior, physical chemical properties, but as well as atherogenic. And for us as clinicians, atterogenicity potential is extremely important. There is a common rule in lipoprotein metabolism. So any particle will become smaller when such particles will lose triglycerides. Okay, great, thank you.
Perfect.
It's never easy. It's never easy like that with a video conference. So let's cross the fingers. Let's hope that everything will be okay.
I'm doing it.
Thank you. So talking about LDL, we have 7 distinct subclasses. So we have larger, more buoyant, and less atherogenic particles. And then we have smaller, more dense, more atherogenic particles. We know since so many years that smaller, more dense particles can be formed by specific action of enzymes as a cascade from VLDL to IDL and then towards larger and smaller LDL. But at the same time, there may be direct production of very small LDL. Thank you. LDL-3 and LDL-4, it means tiny bullets of cholesterol, the so-called small, dense LDL particles. Those are the particles associated with cardiovascular risk. There is a rule in lipid metabolism that when LDL size is smaller, when we have more presence of smaller, more dense LDL, then we have increased triglyceride levels and we have reduced HDL cholesterol concentrations. There is the concomitant presence of 3 different lipid alterations. First alteration is increased triglyceride levels. Second alteration is reduced HDL cholesterol concentrations. And third alteration is the presence of small, dense LDL particles. How we can measure small, dense LDL? It's not easy at all. This is the main problem. This is why it's not a routine analysis. Unfortunately, only few specialized labs, laboratories are allowed to make these analyses, since the gold standard is still electrophoresis, such as gradient gel electrophoresis. In red, in the top, there is the color of oil red O, which stains lipids, and in blue, we stain with massive blue, we stain the proteins. This is the methodology that we use in our lab since about 15 years with gel electrophoresis. And we can easily, very easily, distinguish subjects at low cardiovascular risk or at high cardiovascular risk. This is a good marker. Unfortunately, the quantity of LDL in total is not a good predictor. Instead, by contrast, the quality of LDL is a much better predictor of cardiovascular risk. So this is an example of a subject with a predominance of larger, more buoyant, less atherogenic LDL particles, LDL1 in yellow, LDL2 in orange, and a very tiny, very small amount in red of the dangerous atherogenic LDL, so-called small dense LDL. Please take a look how different is this profile. This may be a patient with type 2 diabetes. This may be a patient with the metabolic syndrome, with a clear accumulation, predominance of the red particles, dangerous particles, small dense LDL, from LDL3 to LDL7. Why these particles are so atherogenic? It is the question for sure. So let's make an example. On the left side of this slide, we have patient A, patient number 1, with an accumulation of larger, less atherogenic particles. This patient will have less particles as a number. The number of the particles is clearly reduced, fewer particles, and all of them, all these particles, are at less risk, which is a good thing. On the right side of the slide, there is a patient with a small dense LDL, which means that this patient has more ApoB, more particles. All these particles are at increased risk. And this may happen, please take a look at the bottom here, this may happen at the same level of LDL cholesterol. So, in other words, LDL cholesterol as a quantity, if we measure only total LDL cholesterol, this may doubly underestimate.
He will connect again.
Manfredi, do you hear us?
Yes, here, I'm here, I hear you.
We don't hear you very well. There are some disconnections, small interruptions. Oh, okay, start again, please.
I will go much quickly, so I will reduce this punishment with this connection. So why these particles are atherogenic? These particles are atherogenic because of reduced clearance by the LDL receptor, greater arterial entry and retention. They stay more in the artery, and there is more susceptibility to oxidation. This is a crucial point. So once these particles are there in the artery, they become immediately oxidized, and we call these particles oxidized LDL. So small dense LDL are, in other words, oxidized LDL particles. Very briefly, without showing you all the details, I can tell you that subjects with elevated small dense LDL, they are usually those with a coronary artery disease, with a myocardial infarction, even with stroke, with cerebral vascular disease, but they are even those with type 2 diabetes. They even those with non-coronary forms of atherosclerosis, such as those with a peripheral arterial disease, and even more subjects with the metabolic syndrome. These are the typical subjects with predominance of small dense LDL. go now very quickly. I will keep a lot of slides, and I will go immediately to the therapeutical modulation of small dense LDL.
Oops.
So usually fibrates, I hope that you can hear my voice now better. Usually fibrates are able to reduce here on the right small dense LDL in a very significant way. So as lipid lowering drugs, they are also effective on small dense LDL. This is exactly the case also for statins. Although there are some differences. Simvastatin, atorvastatin, and rosuvastatin, here, rosuvastatin, this slide, those are the molecules most effective on the reduction of small dense LDL. By contrast, still talking about statins, lovastatin and pravastatin, the so-called first generation of statins, they are not so well effective on small dense LDL particles. Then what about ezetimibe? For ezetimibe, we have mixed contrast data, and it seems that ezetimibe is not able to manage so well small dense LDL. There is even a paradox, like in this study, published 10 years ago with fantastic help of Casper Bernays, that ezetimibe may even increase the presence of small dense LDL. I'm finishing my talk, only 2 more slides, only 2, and then we are done. So, what about type 2 diabetes patients? Traditional drugs such as insulins, sulfonylureas, metformin, they do basically nothing on small dense LDL. Pioglitazone is able to reduce them, but not so significantly. And we have very encouraging data with the use of the GLP-1 receptor agonists like liraglutide. We will talk more about that tomorrow morning, and I promise that we will have a much better connection. We will do a miracle for that in order to have better connection tomorrow. This is my last slide. Please allow me to remember a professor of endocrinology and metabolism, Professor Casper Bernays from University of Zurich in Switzerland, who died a couple of years ago prematurely at 46 years of age. He was such an outstanding expert on small dense LDL. I had the pleasure to be his collaborator and his great friend. So please allow me to conclude this presentation remembering Casper with you. Thank you so much for your attention. Thanks a lot.
Thank you very much, Manfredi. It is a very, very important lecture, and despite some technical difficulties, it was okay for us. Are you still there?
Yes, I'm here. Thank you for your
if are there any questions or comments from the floor? Okay, I have a very short question. If my question is if LDL oxidation is the main point of atherogenicity of small dense LDL, do we have any biomarker for quantify small dense LDL, like ApoB should be or something?
This is an excellent question. Thank you, Christian. We have used in the last years several indirect measurements of small dense LDL, and the common way to detect is with a ratio between triglycerides and HDL cholesterol. So this is basically an indirect measurement based on the presence of ApoB, and indeed many clinicians also use the total amount of ApoB as an indirect estimation of small dense LDL. There is a reason. The reason is because there is one ApoB molecule in each LDL. So more ApoB, the more particles. And when we have more particles, usually we have more tiny, smaller particles. So it's a presence, it's a signal of small dense LDL.